orthopedic surgeons, Dr. Sukhdeep Dulai, Dr. Carrie, Kollias, and Dr. Courtney Bull. Welcome and thank you for taking out the time to be with us today. In Vancouver, I suppose it must be about 8:30, about 7:30 in the morning. So thank you for joining us over here in spite of the huge time difference. For our young audiences who are not well aware, and probably most of the faculty here too, Canadian orthopedics has a very rich history. The Canadian Orthopaedic Association was set up in 1943. And over the years, Canadian orthopedics has had some legendary figures. Robert Salter of the Salter osteotomy, John Wedge, Ian McNabb, who has written the book Backache, Marvin Tile, who gave us the classification for pelvic fractures, Professor Joseph Schatzker, whose work on the tibial condyle fractures and on various techniques of fracture fixation and AO principles is well known. Professor Robert Jackson, my own mentor in Canada, Dr. Hamilton Hall, Mohit Bhandari, Ed Simmons, Charlie Brown, Marcel Dorak, Robert Bell, and this list goes on and on. These are unbelievable figures. Their contribution to orthopedics is immense. And therefore, for the Bombay Orthopaedic Society, this is a very proud moment to be associated with Canadian orthopedics in some way. However, for our Canadian friends and for some of my young colleagues who are watching us on the online platforms, I would also like to share some details about the Bombay Orthopaedic Society. It is a city chapter, but it was the first ever city chapter set up in India. It was the first official orthopedic association in India, way before the Indian Orthopedic Association was started. And today it celebrates 6 decades of continuing excellence in academics, in teaching, and in clinical and scientific work. We stand on the shoulders of some legendary orthopedic surgeons who have taken Bombay Orthopaedic Society to such great heights. Orthopedics in India began in Mumbai. The first orthopedic surgeon was Dr. R.J. Katrak, who established a children's orthopedic unit at the Vadia Children's Hospital, which is today headed by Dr. Rujuta Mehta, who's over here and chairing the session. Subsequently, in 1942, we established the first academic teaching unit at the KEM Hospital in Mumbai. Subsequently, in 1965, a group of orthopedic surgeons, at that time there were just a handful of them, got together and established the Bombay Orthopaedic Society to promote academic excellence and collaboration. In the early years, we used to have bi-monthly clinical meetings, lecture programs over 3 days, which was like a CME and which was incredibly well attended. And soon in 1966, we started Vara, which was our own orthopedic conference. In the subsequent decades, BOS saw a rapid growth. We started doing more and more of clinical programs and academic programs, which included master series CMEs, clinical meetings where there would be interactive case discussions. At one point, Bombay Orthopaedic Society used to host 27 different basic courses on various topics in orthopedics and sometimes even extra orthopedic topics like newer technologies, etc., which were which had helped and attracted orthopedic surgeons from across the country, from across the neighboring countries in India, to India, and from the Middle East and Africa. We've had postgraduate teaching programs, fellowships, and our premier event, VIROC, is attended today by over 1,700 orthopedic surgeons from all over. We have a clinical journal which comes out twice a year. Dr. Harshad Argekar was instrumental in developing an app which would help us to get a consent from our patients. So these are all consents which are available on this app. You have to just download them and utilize them appropriately for the appropriate patient. BOS has also been involved in a lot of research. One of its prime projects, headed by Dr. Vikas Agashe, was on osteoarticular tuberculosis, which was done in 2 phases. Both phases were subsequently published in reputed international journals. So where does BOS stand today? We are an academic powerhouse. We directly or indirectly have been responsible for influencing the thought processes of almost 1/4 of practicing orthopedic surgeons across India. Our legacy has been very strong, but the future with all our young orthopedic surgeons in tow is even stronger. We must innovate. We must educate people around us. We must collaborate with associations such as the Canadian Pediatric Orthopedic Group and try to elevate orthopedic care for all our patients, not only in India, but across the globe. The Bombay Orthopedic Society worldwide is a program that I have set up in order to celebrate our 6 decades of BOS. The goal is to build bridges with societies in India and across the globe and share our knowledge, experience, and expertise, as well as learn from them what is different. Within this program, we have worldwide webinars which are on monthly basis. Last month, our webinar was on tumors, which was with the British Bone and Joint Journal. Today, we have it with the Canadian Pediatric Orthopedic Group, and it's on pediatric hip. We also have a BOS outreach program where the faculty from Bombay Orthopedic Society travels to 2nd and 3rd tier cities across India every month and holds CMEs as well as workshops over there. We also are hosting a real live surgery program, the first one of which is next Sunday, and that is going to be on hand surgery. Top faculty from across India and specifically from the Bombay Orthopedic Society will be demonstrating 15 live surgeries. The BOS is also writing or compiling a series of monographs on various orthopedic topics, one of which happens to be the pediatric elbow. And finally, we run a fellowship program where we invite fellows to do short-term fellowships with some of our experts. So these were some of the events we had in April 2025, a clinical meeting, a worldwide webinar, which was on tumors. There was an outreach program in Aurangabad, which was held on pediatric trauma. And I had a whole host of pediatric orthopedic surgeons from Bombay who came with me. On the first day, we did a purely postgraduate teaching program. And on the second day, we did a trauma symposium. We also have a monthly master series. This month, we had a master series where we talked about complications of hip fracture and salvage of these complications. Next month, we are talking about failed fracture fixation in the upper limb and their salvage. And subsequently, we will be having another one on failed fixations within the lower limb. After this webinar, the next one in June is going to be with the Asia Pacific Ankle Foot Society, where we will be discussing some common problems or common foot injuries which are to be hard, how to manage them. This outreach program was supposed to be today, unfortunately, because of the slight tensions between India and Pakistan. This had to be cancelled because the faculty could not travel there. However, we will be re-hosting it in a couple of months. So more outreach programs. This is the live hand surgery program. As I was telling you, all of you are welcome to come to Jupiter Hospital next Sunday. The program is for free, but registrations are compulsory. And we have a fantastic faculty which will be showing you in detail and explaining to you how these surgeries are to be done. For the first time in many years, we have reintroduced the 7-day format of our basic course. This is the only course across the world which runs on a 7-day format, where we not only have lectures and interactive case discussions, but there are cadaveric workshops, there are live surgery sessions, and the delegates are allowed to go into the operation theater and assist various surgeons during surgery. So it's an intensive training, and people who attend this course go back thinking that, or at least feeling that they should be able to do hand surgery, at least basic, and start off with that. So these are some of the other courses which we have across the year. For all details regarding our courses, you could go to the Bombay Orthopaedic Society website and you will be able to come through them and then register through the same site. Finally, in Bombay, we don't always think of work. We also have a fun. So we have a monsoon picnic, which is on July 26 and 27. And I'm sure people, residents and fellows from around Bombay would like to join us for this. And those of you who like to play sports, November 30th, we have a sports day where we will be having a number of different sports and it'll be great fun. We will release data on this as time to come. The highlight of the year is going to be the 60th annual Western India Regional Orthopedic Conference, which is going to be held between 26 to 28 December later in the year. So, friends, the Bombay Orthopaedic Society has a legacy of excellence in orthopedic education. We have a vision for continuing progress and innovation. And we welcome you to join us in shaping the future of orthopedics, not only in Bombay, not only in India, but across the globe. With that, I hand the mic over to Rujuta to continue with the proceedings for the evening.
Thank you, Gautam, for a wonderful vision for celebrating the 60 years of Bombay Orthopaedic Society. One of the missions for setting up a worldwide webinar was also to set up a dialogue and get to know more of societies from all over the globe. And what pleasure, to be handing over the mic to my dear friend Kishore. Of course, I'll do the formal introductions later. But to share with us a few of the, kind of experiences or things that he would want to say about the Canadian Orthopaedic Association and the CPOG, how they set it up and where it stands now.
Thanks, Rujuta. Thanks for the opportunity. And Gautam, congratulations on 60 years of BOS and all the amazing work that you guys continue to do. And certainly, I remember from my training days in India in 90s, certainly, your city and the surgeons from there were far ahead of other people. And you guys were trailblazers in terms of how you led just the orthopedic innovation and orthopedic advancement, and the rest of the India would often follow. So great to see, some of my favorite people on the screen, both Canadians and Indians. And they all have some connection to Vancouver or the other. So going back to a little bit of history about CPOG, and now it's CPOS, Canadian Pediatric Orthopedic Society. We actually have our current president, Tony Cooper, who is on the screen. He's there. He joined us and he's listening to the webinar right now. Also, I was the founding president. This group started in 2012. It's one of the sub-societies within Canadian Orthopaedic Association. It grew from few people, and the main, person that actually got us and pushed us to start is late Dr. Lucas Monahan. But the person that really led us getting together and moving us forward is Sukhdeep Dulai, who's our current president-elect of Canadian Orthopaedic Association. And she followed me as the inaugural president, and this society is in great hands with Tony now, and he'll soon be handing off to one of our colleagues from Ottawa. So with that history, I'll introduce the three speakers. Rujuta, are you going to introduce them?
I've got the slides ready for you.
Fantastic.
So I'll just...
No, you can go ahead, or I can.
No, I'll just put the slides.
Fantastic.
We'll do a ladies first approach.
Yeah.
So there is Kishore. Of course, he needs no introduction, but he is somebody who is a big visionary himself. And he's the founder of the Hippie Lab, the GHDR. I mean, those are his current positions, but if you just look at how many publications he has, it's overwhelming. And, you know, huge amount of work, huge amount of global connect. I think we'll get to know more of him as we go along. Let's move on to the other introductions. That's the introduction of Sukhdeep for you, Kishore.
Yeah, Sukhdeep is a dear friend, and she came to Vancouver to do a fellowship. And since then, you know, I would say is remained as a very close friend. If I need some sage advice, and I'd reach out to Sukhdeep, and you can trust Sukhdeep to tell you as she sees it. In a very supportive way. So one of the most authentic leaders that Canadian Orthopaedic, I think, has ever seen. We're fortunate that she is now a president-elect. Some of the notable distinctions, and you can see she is a full professor, a woman orthopedic surgeon that is a full academic professor. There's very few. There's 3 of them in Canada, so she's one of them. And what Sukhdeep really brings is a real passion to anything she gets involved in. As I mentioned, CPOG or CPOS, what it is today is actually because of, I think, what Sukhdeep started. She was a ABC fellow in 2019, and certainly I think that had an impact on her and her career. And she is now, or one of her main focus as she is working as a president-elect of Canadian Orthopaedic Association is on wellness. And her interest, I think Sukhdeep does everything in pediatric orthopedics, but a major part of her focus is limb deformity, hip dysplasia, neuromuscular disorders. But really, if anybody's got any complex pediatric orthopedic condition, and I think Sukhdeep is the person that you go to. She currently works in University of Alberta at the Children's Hospital in Edmonton. You will continue to see in years to come from her contributions. Next, we have Carrie, right?
That slide showing?
No.
Oh.
We have Sukhdeep's slide. I'll start talking. Carrie Kollias is a colleague of ours right now in Vancouver. She joined us last year in 2024, and it's been a game-changing for us in terms of, I think, our group and what we're doing. Our clinical focus is on baby hips and also limb deformity and pediatric foot. She had extensive training. She trained in Alberta, then went to do her fellowship in Melbourne. Came back and worked in Lethbridge and Alberta, and then went back to Melbourne and was attending their vice chair of the pediatric orthopedic department at Royal Children's Hospital. Incredible place, Royal Children's. And then she came back to Canada. We're fortunate to have really, able to bring her to work with us in Vancouver. She's currently a co-director of mentorship and wellness in UBC Orthopaedics. She is also an author of an award-winning children's book, Maria's Marvelous Bones. And this is, I think, one of the first attempts that I know of in pediatric orthopedics to bring children a comic book as they are getting treated for their fractures. So quite innovative. It's, we have few copies in our clinic. And Carrie is one of the most inspirational person that you will meet, and incredible leader. and we will see a lot more of Carrie's leadership in years to come. Courtney again has a Vancouver connection. As you can see here, she currently practices in Saskatoon, Canada. She again has taken on all of the complex stuff that comes to her, certainly with a lot of interest in DDH, limb reconstruction. She did a residency in Memorial University, and she has a master's in healthcare and epidemiology from University of New York in England. And she came to us in Vancouver for a pediatric orthopedic fellowship. Since then, we've been trying to recruit her back unsuccessfully. And Courtney is again a very good surgeon, a great teacher. She won the teaching award the year she was here with the fellows. She's again, there's a lot more to come from her in terms of Canadian orthopedics and global orthopedics. Thank you, Sukhdeep. Over to you.
All right, I'll just take a short introduction on all our BOS boys. That's Alaric Aroojis, who's the current Pediatric Orthopedic Society of India president. He has a huge list of accolades, a very sharp wit and a very sharp rhetoric as well. Several books, several chapters, several articles, and a lot of accolades to his credit. And along with him, we have Dr. Sandeep Vaidya, who is also a consultant at the Vara Hospital Pinnacle Ortho Center in Jupiter. Huge amount of interest in lower limb deformities, CPT and hips as well. And again, very prolific author, won several best paper awards and co-author of a book on pediatric trauma. And young and dynamic Chintan Doshi, now a consultant with many hospitals in Mumbai and fellowship trained in Vaidya, Singapore, and many other places. A lot of achievements to his credit as well. And knowing the format of this webinar, that's just quickly for the audience to recap. This is going to be the order in which we take the presentations. We'll start with Dr. Sukhdeep Dulai, followed by Dr. Alaric, Dr. Carrie, Dr. Sandeep Vaidya, Courtney, and Chintan. So whatever questions you all have, please do send it in the chat box and on the channels. Kishore and I will be moderating, but everybody else is also free to ask questions at the end of each case. So do put up your hand. So without wasting further time, let's start. Sukhdeep, opening batsman.
Okay. I'm assuming you can see the slides.
Yes, all okay.
Great. Thank you for that very kind introduction. It's a real pleasure to be here. I'm just going to run through this case. Please try and think what you would do in this case, and we can discuss it at the end. Just in the interest of time, I'll run through it first. So this was a 7-year-old boy who was run over by a very large vehicle and sustained numerous very severe orthopedic injuries, including an unstable pelvic fracture, a large degloving injury over the right buttocks and lateral thigh, a right femoral neck fracture, which you can see here, and a lumbar plexus injury. This was done at a different center, and they proceeded with emergently fixating the pelvis with the external fixator and placing cannulated screws across the physis for fixation of the fracture, which really is like a Delbit 1-2-ish. It's more a crush type fracture, but that's in the region of where it is. And then went back and fixed his posterior pelvis with sacroiliac screws. He healed up those injuries, and the external fixator was removed along with the cannulated screws. I must say that I don't typically remove cannulated screws across the femoral neck this early, but they may have been anticipating some of the complications that this patient was at significant risk for, or maybe perhaps even just trying to avoid a growth arrest given his young age. Watching for, knowing that he was at high risk for complications, he was followed, and indeed he did develop those complications, including what you can see here, changes consistent with avascular necrosis of the femoral head, as well as a growth arrest of the proximal femur. Now, because he was still recovering from all those other injuries, including the soft tissue defects as well as the nerve injury, and because his function from the particular hip issue was not that bad, the decision was made not to do any intervention at this point, despite the fact that you can see a little bit of uncovering of that head, especially laterally. The patient subsequently moved cities, and that's when he was transferred to my care. And this was him a few years later, at 13 years of age. At this point, he was having symptoms, particularly pain in the hip with activity, and he was fatiguing very easily. He also had an abnormal gait, which we'll discuss briefly. So if you look at these radiographs, you can see that his femoral offset is reduced. That's from the center of the head to the long axis of the femur, as we all know. We can see that the articular trochanteric relationship is reversed with the tip of the trochanter higher than the joint. We can see that the neck shaft angle is reduced, indicating some coxa vara, in addition to the coxa breva that we saw earlier. And then we can see that there's a little bit of coxa magna and coxa irregulare with the changes in the femoral head. Well, there's also, I just outlined some new bone formation just off of the iliac crest, which was related to his previous injury, but significant because perhaps that is also impinging when he abducts his hip, given the height of the trochanter. So on clinical examination, he had decreased hip abduction as well as increased anteversion, and he had some weakness in the hip abductors, although they were functioning more than anti-gravity. He had a mild fixed flexion deformity of the hip, and his soft tissues were healing, were nicely healed, but there was very significant scarring on the lateral aspect of the thigh. When you assess his gait, which I don't think the video is going to work as usual, but that's okay, you could see that there's some atrophy of the right leg, which you can appreciate on this image, as well as a lean of the trunk to the right side when he's standing on that side, and toe-toe walking on the right side. We obtained a scanogram. Now, interestingly, when he stands clinically, he looked like he had about a 3 centimeter difference. But remember, that's hard to judge because of all the trauma that he had around the pelvis on the right side. And so he was imaged with a 3 centimeter block underneath the right hip, and you can see that overcorrected his limb length discrepancy. His actual discrepancy was 1.5 centimeters, with the right side being shorter than the left, and that difference primarily originating from the changes around the hip. So in summary, we thought his problems included changes in the proximal femur due to avascular necrosis and the growth arrest, as discussed, weak abductors from both the soft tissue injury, perhaps the nerve injury as well, and the reversed articular trochanteric distance, which would have disadvantaged the abductors. And then toe walking on the right side due to a combination of the limb length discrepancy and his a foot drop that was secondary to his nerve injury, but partially resolved at this time. So we proceeded with a Morcher osteotomy, or I guess our version of a Morcher osteotomy. So this involves 3 cuts, all parallel to the femoral neck. One at the now reports improved strength and stamina and has returned to his normal activities. He is using an AFO for his right foot, and we'll make a decision about whether or not he needs anything further with regards to that shortly. So I'll open up the floor to discussion or questions.
So the way this is going to work is the other 5 faculty here are going to be panelists for this case. So anyone wants to ask the first question?
Can a non-panelist ask?
Oh, sure.
Yeah. So Sukhdeep, there is a question from actually the audience. Dr. Matthews from Kerala in India asks you a question that would you have done the primary hip surgery any differently? Would you have used smooth pins or something, or would you still stick to a cannulated screw that was used originally? And the second question is that the same person is asking is whether what is the earliest age today when you would consider a hip replacement, not necessarily in this case, but would you consider a hip replacement to salvage a bad hip in a child?
Okay, thank you for those questions. So I think in terms of fixing a femoral neck fracture in a skeletally immature patient, I think really the concept is you want, stable fixation and as anatomic reduction as possible. If you could obtain that with smooth pins, I think the idea there is, could you avoid the growth arrest? I'm not sure that the screws can be blamed for this growth arrest. In fact, I don't think they are. I think the amount of trauma that occurred around the growth plate is really responsible for that. And no matter what they fixed it with, it wasn't likely to continue growing, and the AVN risk was very high for this patient. But I don't tend to use smooth pins, but I think that what I might do is use a partially threaded screw. Sometimes I'll do that, and then plan for removal. But I don't think there's anything wrong with using smooth pins if that's what you chose to do. I think the key for us is really that they have to be in there for a while, and so leaving them percutaneous, especially in a patient who has a very significant amount of soft tissue trauma, you'd be concerned about getting infection. And so I probably would avoid that. With regard to the question about hip replacement, my residents know saying hip replacement or total hip arthroplasty in the pediatric clinic is like using swear words. So I don't encourage it. I definitely wouldn't be thinking about it that in this particular patient, because arthritis, wasn't really his significant complaint. He wasn't having that type of pain. He was having more fatigue pain. But, we do have some patients in their teenage years getting hip replacements for other pathologies where there's been significant loss of joint space and significant arthritis and pain related to that. Yeah, so.
Hey, Sukhdeep, there's a request to go back to the first slide, pre-op. Somebody wants to see the pre-op.
Okay.
Yeah, and meanwhile, there's a question from Dr. Abbas Ali from Canada. Thoughts on Morcher through surgical hip dislocation approach versus standard supine lateral approach, and preference for a fixed angle device blade plate versus a locking plate and subsequent effect on trochanteric fixation.
Yeah, so I would say I'm going to answer the second question first. So I would say that a proximal femoral locking plate is a fixed angle device. I mean, you could use a blade, but I find with this particular surgery, and I do usually use blade plates for my proximal femoral fixation when I'm doing osteotomies, but not in this particular surgery, just because you're dealing with multiple fragments and getting the chisel across and then the blade across, it's just a little more difficult to control. I mean, you could put some pins in, but then they're in your way. So I tend to use the proximal femoral locking plate for this, but definitely you could use either. The first question was about you doing it through a surgical dislocation approach. I guess really that depends on what else you need to do. I think if I tend to do this through the lateral approach, just because we're not often going in there to do concomitant procedures on the actual femoral head. Maybe someone could argue, would you want to do a bit of a osteochondroplasty on that head? But once we had this hip reconstructed, we did put it through a range of motion, and there wasn't any evidence of impingement or any other issues that made us feel like we should go ahead with that. But if you were thinking of doing concomitant procedures on the femoral head, then a surgical dislocation makes sense. But remember, then you're also increasing the risk to the femoral head. Now, this head has had AVN and recovered, so I guess the question is, are you going to give it another insult?
Any of the panelists wants to ask anything? Carrie has raised her hand.
I was just going to comment on that original question about hip replacement, and so I think this has changed even from the last 10 years, and historically it'd be like everything at all cost to avoid hip replacement, but now we're definitely every hip like this. When I think like reconstruction, okay, how is that going to affect the late definitive total hip replacement when this patient is in 20 years and whatnot? So I think this is Dr. Dulai that's a lovely I think outcome for this patient, but I think we're always thinking now, what's the next surgery down the road in the future, and will this surgery make that arthroplasty surgeon's life more difficult? And so we really try to take that into account.
I think that's true. Yeah, that's a good point, Carrie. I mean, it's not that we don't ever think about it, but I think you should be considering reconstruction, given that we still don't have implants that will last forever. The other thing is you have to consider your environment. And in India, I would think, you need to think about the patient setting and whether or not a hip arthroplasty is going to be the right thing for them starting out from childhood. And, there are local considerations that you should really be thinking about as well.
Yeah, there's a question from Sandeep. I think, Sandeep, you can go ahead and ask it yourself.
Yeah, so, this month's issue of JPO, Salil Upasani and the Radis group, they published the utility of bone scan 3 months post-operatively to look for AVN, and which if present, so even before the X-ray features of AVN are visible, you can take preemptive measures like bisphosphonates or drilling and of the epiphysis. Any thoughts or comments or any experience with that?
Yeah, so actually my experience is from the setting of SCFE actually with bone scan, doing bone scan in unstable SCFE. And I don't know, Sandeep, if you loaded that question, because my fellowship project was on bisphosphonates in APN in children's hips. So my advice to people really is, the bone scan is useful for early detection of AVN if it's going to change what you do with the patient. Now, some people don't do anything different until they actually see radiographic findings of AVN. If that's the case, I don't know that an early bone scan is really useful. But I think if you are going to do something about it, whether it be bisphosphonates, whether it be offloading the hip for an extended period of time, which I often will do in my unstable slips that have a bone scan showing signs of AVN on their initial scan, then it makes sense to do it. I think drilling of the epiphysis in this patient, then, if you decided to proceed with drilling of the epiphysis, because it's whole head AVN really in this patient, so you'd be committing yourself to a growth arrest of the proximal femur, because that's what you would be doing. You'd be drilling across the physis as well. And so you're going to get all the problems in relation to that, given that he was so young, like he was only 7 years old, I believe, when he started. So I don't do a lot of drilling of the epiphysis in younger patients unless it's a very focal deformity, a focal lesion, I should say. But I think that's the consideration. If you're going to do something differently, then sure, an early bone scan makes sense. But if it's not going to change what you do, then what's the point?
So lovely start, Sukhdeep, and I think in the interest of time, we'll keep moving, and I would request you to stop sharing. Chintan has brought out something, the procedure done tackle the head trochanteric relation shortening, but what if the intra-articular head problems persist? So to probably throw some more light on another type of avascular necrosis and what happens when the intra-articular head problems persist, I now invite Alaric Aroojis to take us through another case, very and similar sort of thinking on shelf arthroplasty for advanced Perthes disease.
Thank you, Rujuta. That was a great start to this wonderful webinar. And fractures are always interesting. There's, I'm sure, a whole lot of discussion that can happen around your case. I'm going to go and segue into another controversial topic in pediatric orthopedics, which is Perthes disease, and especially the role of the shelf osteoblastoplasty in advanced Perthes. So here's my case of a 10-year-old boy who presented with limp and pain in the right hip of 15 months duration. Clinically has an adduction deformity of 10 degrees, restricted flexion from 10 to 18 degrees, and external rotation deformity of 15 degrees with very limited further external rotation. So basically quite a stiff hip. And the X-ray, as you can see, shows that there is advanced fragmentation already with a lot amount of metaphyseal reaction. And this would be put under the modified Elizabethtown classification as stage 2B. So the clinical conundrum here is, of course, the first would be how to restore the range of motion, which we know is one of the most important elements in Perthes disease. And then thinking long term, how do we approach this hip so as to minimize femoral head deformity at the end of skeletal maturity, which is what we're trying to achieve in children with Perthes disease. And therefore, the question that arises here is, do we contain or not contain this hip? I think the decision making is quite clear in Perthes disease. It's simple to understand, but not always simple to put into practice. But it hinges on these 5 important parameters: the age of the child, the range of hip motion, the stage of the evolution of the disease, and what we use now is the modified Elizabeth-Town classification, the extent and the grade of epiphyseal involvement by the salt of the catwalk grading, and finally the extent of collapse, which manifests usually in the advanced fragmentation stage, classified by Herring or by the Reimer's extrusion. So here's the landmark paper that came out from one of the stalwarts of Perthes disease, Professor Benjamin Joseph, and here's a paper published by him with Kishore as a co-author, which really showed us the optimal timing for containment, saying very clearly that femoral head deformation occurs in early healing stage. And therefore, containment is to succeed, it should be achieved before this, and showed very nicely from a large series of cases that the odds ratio for obtaining a spherical femoral head, that's a Stulberg 1 or 2, was more than 16 times higher if the surgery was done before stage 2B. And that brings us to the question of what do we do with this little orphan hip standing there, which is often the oddball when it comes to management of Perthes disease, because I think the principles are quite clear for stage 1, 1A, 1B, and 2A, and again for the healed Perthes disease. But what happens with this intermediate stage? Is it too late to salvage, or is it too early to condemn this hip? And therefore, this leads to a lot of confusion in the mind of the treating orthopedist. Should we attempt containment? Do we do a salvage? If we do a salvage, what type of salvage option would work in this patient? My philosophy for treatment of Perthes disease is what I've understood from literature, and I think great publications from various experts in Perthes disease, but especially Professor Perry Schenecker, who showed that there are 2 types of extrusion in Perthes, a reducible and a non-reducible variety. The reducible variety especially is interesting to us because it presents with this progressive loss of abduction internal rotation. It's usually seen in the stage of fragmentation, either early or late. And this is the treatment that has been recommended by Perry Schenecker's group, is to examine this child under anesthesia, do an extensive medial hip release, put the child in a Petri cast, and then decide about whether you want to contain this hip or not. So following those recommendations, this is what we did for this child. We took the child under anesthesia and performed an extensive adductor release, as you can see from the soft tissue shadow there. I do not hesitate at times, if you're not getting adequate abduction, to go right down to the medial hip capsule and do a formal capsulotomy. Immediately, we found that there was a marked improvement in range of motion, and the head could be contained well within the Perkins line, as can be seen here. And very importantly, you must be sure that there's no hinging on the arthrogram. We then proceeded to put this child in a Petri cast for 3 to 4 weeks. Once that was done, before the child could lose any range of motion, we then proceeded with a secure shell procedure. And for those of you who are not very familiar with this technique, it's the exact way that Lynn Staheli described, where we put in a cortical graft over the superior rim of the acetabulum, extending it out laterally, not too much anteriorly so as to prevent impingement, and then layer it with a whole amount of cancellous graft, as you can see on that X-ray, and then secure that with a plate, because now this is a large head which wants to extrude out, and unless you secure that with a plate, very often you'll see the graft resorbing very soon. So here's an early follow-up at 2 years, and as you can see, this was the original extent of that acetabulum, and because of the shell, we managed to extend that out by almost 30 or 40%, and that's covering this large, capacious looking head. And that's what you can see on the lateral view as well. Similarly, we have got a few other cases of the same sort. Here's a 12-year-old boy who presented to us more than 10 years ago. And here again, you can see a long-term follow-up at the age of 23 with a large shelf out there. And the head pretty much well contained, though he came to us at a fairly advanced stage. So that's my case, and I'd like to pose these questions to the panelists. There is still a lot of controversy on the role of shelf acetabular and even the shelf acetabular-plasty, and especially the management of these intermediate hips who present with Elizabeth-Town stage 2B. We still don't know whether we actually change the natural history of this hip, Is containment actually an option in this intermediate stage of hip of disease evolution? And I'm always have that fear in the back of my mind. Are we doing any more harm than good? Though our initial results with this technique have shown fairly good results in this group of patients. Thank you very much for your attention.
Discussion.
Thank you, Al, for that presentation and giving a really nice overview of I think, Perthes and timing, and then what you've done. Why don't you stop sharing and we'll go to our panel. We'll start with our Canadians. So, Carrie, would you do anything different, or what are your thoughts on, I think, what Al did?
I mean, I think what you've done is excellent. I personally, don't have a lot of experience doing shelves in Perthes. Likewise, in Melbourne, that wasn't particularly common. But I think what you've done is lovely, and I mean, I hope we'll understand more in the future what the right path is with clear evidence. But yeah.
Sukhdeep always will have some controversy of how she would handle it differently. So let's see.
I don't know if that's a compliment or an insult, but I think obviously it's hard to argue with success, and the patient's looking great, so that's a fantastic thing. I thought it's interesting that you are fixing the shelves. I use more of the technique that was published by Will Mackenzie's group, where you use struts to stabilize the graft, so then you don't have fixation in there that you have to deal with in case they do have problems later on. The other thing, I guess the other question I have for you is that hip reduced, right, on abduction. So why did you decide to go with a pelvic sided procedure on a hip that reduced adequately?
Great, thanks, Sukhdeep. Great questions. So shelf is something that we also don't do very frequently, but we select the cases out which benefit from a shelf osteotomy. And especially for cases like this, where the hip is irritable, the head is large, we have often found that if you don't secure that with a plate, very often that graft will resolve very quickly. The second question about now that we found it's containable, a varus osteotomy versus a shelf. And I think a varus osteotomy in a late stage of Perthes is not a good option. We already have a head which has declared itself that it's not going to be a Stolberg 1 or 2. It's going to be a large mushroom-shaped head. We're going to have proximal growth problems in this hip. And we're going to land up with a large-looking head at the end of whatever we do for a stage 2B Perthes and advanced fragmentation. So I think we reserve a femoral procedure when we are doing containment prophylactically, or when we're doing it in the early stages of disease, stage 1A, 1B, or 2A. But the minute I go into stage 2B hip, and an orphan hip like this, where we really don't know what the outcome is going to be like, I think a varus osteotomy can do a lot more harm than good as a form of containment. And that's where we prefer a shelf procedure, because no, you're not changing anything in the proximal femur now. We know that this hip is going to have proximal femoral varus going forward. We know you're going to have some amount of trochanteric overgrowth here, and therefore the pelvic procedure, in fact, is something that I would prefer for this stage of the disease. Thank you.
Well, Courtney, would you do anything different?
I thought that looked great as well. My question was kind of mirrored by what Sukhdeep had questioned, why the pelvic sided versus the femoral sided osteotomy, but you answered that nicely. Thank you.
Sandeep, are you also like Al on the pelvic side or on the femur? Or certainly for me, I'm more of like Ben Joseph, so I'm more on the femoral side, because I think the problem is there, right? And most of those varus will remodel. I've not seen that varus that you put in stay, especially in young kids, and that'll completely remodel. What's your
so till stage 2A, I think we all follow Professor Joseph's recommendations regarding prophylactic containment in the late onset Perthes. But I think 2B is a very controversial topic. surgeons all around the world, they are still not, there is still no consensus regarding, how to manage these hips. And I have learned my concepts of Perthes largely from Alaric. So, I would go with the same procedure, initially restore the range of motion by doing a medial release and applying a Petri cast. And once you get a decent range of motion, then go for shell. I think the reason, as Alaric pointed out, the reason why we go.
Sorry, we lost your voice, Sandeep. We still can't hear you.
Yeah, just to reiterate
Hello?
that point. Yeah, sorry, we can hear you, Sandeep.
Okay, sorry. So, 2B is a very controversial, hip, because there is no consensus as to, how to manage these hips. Till 2A, we all follow Professor Benjamin Joseph's, recommendations regarding prophylactic containment. But 2B is a stage where I feel, that biological plasticity of that femoral head is limited. So even if you do your, virus derotation osteotomy, there is no way I think that head is going to.
We lost you again.
So I'll just clarify that while Sandeep comes back. Kishore, for us, the containment procedure for Perthes disease is a femoral varus osteotomy. I'm bringing up a specific type of stage of the disease, which is 2B, as Sandeep is also pointing out, that this is the stage when I would avoid doing on the femoral side. So in case that point got missed, the procedure of choice for us for containment is a femoral varus, except for this one particular condition, which I want to highlight from this case.
Chintan, you had your hand up.
No, yeah. So I wanted to ask, the shelf was actually very big, like, almost 30-40% of the rest of the roof. So are we worried about getting an impingement in the later stage, like when the child grows up, or, it was quite protruding out onto the neck. So not sure whether that will act as a pincer onto the, give you further hip pain at later stage.
Great point, Chintan. What we have seen with our follow-up case, and I can't claim that we have got follow-up of 30 or 40 years, but other follow-up we've seen is that the graft will remodel with the mobility of that hip. We take care that we don't put too much of graft anteriorly. We don't want anterior impingement. We check that out and we range the hip when we put the graft in. Laterally, again, we have to ensure that we have got a good amount of abduction and we don't get trochanteric impingement. So the amount of graft that we put in there and the shells that we create is important. But at the same time, we know from our follow-ups that whatever extra bone is there, at some point with time will get resolved. So it's rather better to put a little bit extra than a bit too less. I've seen often shelf osteotomies where a tiny little piece of bone is stuck in there, and it doesn't do really much for that hip at all. So I believe that if you're doing a shelf, you do a proper job. You have to balance it out between really supporting that extruded femoral head versus causing impingement. And I think little by little, you get that experience as you keep doing more of these procedures. Thank you.
Fantastic. I was told there's about more than 500 people online, so that's really great. So we don't want to keep them too long because it's getting late in the night in India. So we'll move on to the next presentation.
Carrie.
Perthes, we could keep talking till tomorrow.
Okay, good evening, everyone. It's a pleasure to be with you. I have no disclosures. This is a tale of Coxa Valga. So think back to 2015. There were some rather famous movies that came out that year, but I want you to think about a surgery that you enjoyed planning and doing 10 years ago. Now, think about whether you're still doing it the same way in 2025. Now, in most cases, the answer is probably yes. And in this case, I could not have imagined how differently in a 10-year period I'm doing a Coxa Valga reconstruction. So this story starts in 2012 with a 5-year-old male refugee who presents with waddling gait, and he has Coxa Valga, and no, the skeletal survey is normal. There's no medical or genetic cause found. And I decided at that point, I'll check him out again in 6 months and see where this is heading. But which does happen in Canada, which I expect probably happens close to home for you as well. He's lost a follow-up. And he comes back in 2015. He's now age 8. And it's pretty clear that this kid needs to be sorted out. And it was pretty clear what he needed to be sorted out too, because we had pretty good evidence. And I knew if I could get that Hilgen-Reiner epiphyseal angle down to, to a respectable amount, he had a high chance of not recurring. And so I knew how to get there because I had extensive experience in my fellowship time at Royal Children's in trauma CAD planning, again, two-dimensional. And but when I started practice in regional Canada, I did not have that expensive platform, but thankfully at that point, Bone Ninja had come out. And so this seemed pretty straightforward to me about what needed to happen. So this is some of my old planning x-rays. You can say, well, I was going to plan probably a 100-degree blade plate. Okay, and if you can see that there, that's what he got. He did fine, decent work. Maybe nowadays you maybe change it to a cannulated blade. But let's just tell you what's happened the last even 6 months for me. So this is Coxa Valga correction circa 2025. And when I joined here, the awesome people that have worked very hard ahead of me to get this in-house digital lab here at BC Children's has been a total game changer for me. And so this is a case, there's two femurs here. There's a spondylopiphyseal dysplasia, tiny 10-year-old on the left, and then a congenital femoral deficiency case on the right. And you can just see that's my hand. My hand isn't that large. You can see these very small bones we're talking about here. So let's go to this spondylopiphyseal dysplasia case, bilateral Coxa Valga, significant disease. And this is the MRI. And there's no pseudarthrosis present. So this is, what do I need to give the digital lab to get me those custom-made cutting jigs? Well, I need a full-length femur CT, and you can see here significant varus, there's significant retroversion, and in her case, there's actually even a 2-centimeter leg length difference. And so we give them this CT, and they analyze the deformity. And we tell them what we want them to get to. So we say, well, I want maximum 1 centimeter, total lengthening, so I don't pick off the sciatic nerve. I want anteversion to 14, say from retroversion of 30. And we start trying out different implants. This is locking a plate. And you can see here that what happens is there's this they come up with this custom jig. And you can see the 2 slots for a drill osteoclasis to be performed. And then the gray component there is an outrigger to guide the rotational correction. And those wires going into the head, actually, we use those to guide the plate on. And so this is actually showing an intra-op version. So the clear picture in the middle is the actual cutting jig that is made by the digital lab in-house and sent to medical device reprocessing to be sterilized. We have 2 copies of it, as well as a sterile bone, 3D printed for the set. And you can see this is showing on the fluoro on the right with the jig in place with the wires. And I should mention there's a little bit of a fiddle factor in getting that to key in really precisely on the proximal femur. This shows intra-op how the drill osteoclasis, so we're actually taking a segment of bone out so we don't over-lengthen, then showing the plate sliding on, and then showing what it looks like at the end. And so this is that other case I showed you at the beginning with the congenital femoral deficiency, which is a Paley, in that case, 1C turned out to be a 2A, even though the MRI didn't show a pseudarthrosis. But this is been a total game changer for me because, these small bones, these high stakes cases with a lot of abnormal anatomy, inadequate ossification, it's really helped proceed more efficiently in the OR, more confidently. And also, we think removing those outliers and yeah, this has been transformative. So stay tuned. Thank you. Open that up for questions.
Wow, nice touch there, Carrie, to get both the pictures in from Star Wars to Bahubali. I think it's very nice to see 3D technology being used because it helps you to see exactly and go exactly where you want to. Now that we are seeing in real time what is actually you're seeing in the mind. How would you, kind of place this in terms of if you have a center where you cannot avail of this technology? Is there still some way where you could have a pre-op planning or to execute it with this finesse?
So I think understanding what you have at your disposal. I mean, up until 9 months ago, I didn't have access to this. In Melbourne, we didn't have access to this. We would I mean, it's started becoming sort of available, but only you try to find $3,500 Australian from somewhere, sometimes from the patient. It was all a bit suboptimal. I think at least starting with the 2D digital, like actually using Bone Ninja. You can use PowerPoint in planning things well to start with. One of my concerns with implementing and using this current technology is what does this mean for the training environment? We have a lot of global fellows that come to Vancouver and they go back and they don't have an in-house digital lab. And I recognize that. And so that's always on my mind. So I'm teaching, okay, when you go back home, this is what, this is how I did it for 10 years and it worked out well. You would probably, you would not do a 3.5-year-old with maybe congenital femoral deficiency at age 3.5. You're going to wait till they're bigger, just because we know that the complication rates are higher in that under 5 category. So I think optimizing the 2D is key, but this is an area that's changing fast. And there may be I don't know, I'm sure this is being used in India. I would open it up to the national people there to tell me what's happening there.
Yeah, so Sukhdeep's raised her hand, and before I hand over to her, what I'm trying to ask in a sense is take us through your decision-making points for this particular etiology and the treatment that you've chosen.
So why did I do the 3D model?
Just for the benefit of the general orthopods who are tuned in.
Sure. Okay, so I'm first I'm looking at the patient clinically. Do they have a flexion contracture? What's their retroversion? How much am I wanting to get that Hilgenreiner epiphyseal angle to? So I want to be, less than 38 degrees with that. And, how much is the absolute lengthening that I'm going for? Because I would want to be less than a centimeter. The other thing in this case, which you should see, I should mention, I did use spinal cord monitoring throughout for this patient. She had significant lumbar lordosis, and there are some case reports of patients with long surgeries waking up paralyzed. So that was another consideration, careful positioning. And so planning the correction in each of those planes and how I'm going to get that. And so I would, I still, in this case, I bone ninja'd all of this out, even though I had the 3D lab, because I'm still a bit of a defensive pessimist. So if the whole thing goes down, so yeah, I hope that answered the question, but Sukhdeep.
Yeah, thanks, Carrie. I have to admit, this would cost me so much to try and get here that I don't use it for my cases, but it's beautiful, your result. I guess one comment, one question. One of the things I found, intraoperatively to help visualize when you do have an area of the neck that's not ossified is just doing an arthrogram. It makes it a lot simpler to know where to put those wires in when you're doing your osteotomy, if you don't have the luxury of having the 3D model. I guess the biggest, one of the bigger challenges that I've noticed is finding instrumentation that fits nicely. I think that is, probably the bigger problem is finding the high angle plates that will allow you to get that proximal femur into enough valgus. I'm not going to tell you my own solutions to that, but I'd like to hear what your solutions are to that, or what you suggest for that.
So that's that's, I think, the real benefit of doing all that, the 2D planning on Bone Ninja or before, because I can tell, like, originally I was like, okay, well, could I use a blade? Well, I could, but in this case, because of the the real estate available in that location, that was clearly is not going to be feasible. So now with the high locking angle plates, the infant size and child size, there's a lot more options available than we had even 5 years ago. So I plan these meticulously to see if this is viable in the 2D, and then digital lab really helps me confirm that, especially in terms of that anterior posterior width, because the concern is, am I going to get fixation enough in the head and neck? Yeah. And I agree with your arthrogram point. Actually, on the other side of this case, I actually ended up doing the arthrogram because the head you could hardly, you'd still see it. You could hardly see it. So I still won't like just blindly put the jig on and fire. I'll be like, no, I'll inject arthrogram and be able to see everything. So
I think that's key to anybody who's going to do this. What you said is, really, you have to think if you have the proper implants. You do not want to get in there and realize you don't have the properly sized implants or the proper size angles, or you don't have benders for your plates if you don't have the high angle plates. That can really get you in a lot of trouble. If you don't have it, you probably shouldn't be doing these cases.
So we have
Dr.
Chintan's question now, and then if Alaric is asking anything different, we go ahead with his as the last question.
Hi, Carrie. So the one you asked that you wanted to know what we are doing. So we also have access to 3D printing models. Other thing that we were discussing just with Sukhdeep ma'am also, that arthrogram would help in the non-ossified head or a non-ossified neck. But we do have a software where we can plan this 3D printing even on the MRI, apart from the CT itself. So the same jigs can work on MRI, and also percutaneous osteotomy can be done if at all you are doing it with fixators. So we can place the jigs on the skin itself and do a percutaneous osteotomy and do correction with fixators as well.
Thank you. We had an MRI as well to try to overlay. Now, interestingly, in both of these cases, the engineer Eric, he didn't have to use the MRI, so these were based on the bone. But yeah, this is a fast moving area. Okay, thank you.
Did you want to ask anything else?
No, very quickly, I'll just say, Carrie, that was a very elegant demonstration of using precision technology and patient-specific jigs, and that's the way the world's moving forward now. I don't want to ask about cost because that's a burning question in everyone's mind, and I know it varies from healthcare system to system. But my question is more basic. I just want to ask about the role of trochanteric epiphysiodesis in cases like this. I didn't notice you had drilled the trochanter or put a screw across it, because very often there's a very high chance for recurrence if we don't deal with the trochanter. Thank you.
Yeah, thank you. So the plan is when the these plates come out, well, certainly for the younger patient, it's gonna, that will be relevant. For the 10-year-old, I mean, the trochanter is quite hard to arrest as it is. I didn't want to go, trying to, I suppose, complicate my otherwise complicated surgery with that, but that will definitely be, I don't think it will happen in the 10-year-old because there won't be sufficient growth remaining, but typically, yes, if it was, say, a 7-year-old having this, then when I went to take the plate out, I would go back, I would do it at that point.
All right. So in the interest of time, thank you, Carrie. We'll move on to Sandeep, and there's a question for you from Marcel Abu Saleh. Maybe you could answer him on the chat since he's on the faculty link anyway. So Sandeep, can you share your screen, and Dr. Kishore will moderate this.
Yeah, I hope I'm audible.
All well.
All well. Okay. So I am now presenting this case of a 14-year-old boy who presented with a history of a trivial fall, followed by a fracture of the femoral neck, which, as you can clearly see, it's a pathological fracture. So this is a fracture through a large cyst in the femur neck. The extent of the cyst is right from the level of the physis. So this neoplasm, it is abetting the physis, but fortunately the lateral wall is intact. Now, due to the comminution and displacement in this fracture, we couldn't make out the exact characteristics of this neoplasm. We wanted to be absolutely sure before the definitive surgery that we are not dealing with a malignancy. That's why we decided to do an MRI first. And in the MRI, what we specifically looked for is, are there any solid components and are there any enhancing components on the contrast? But fortunately, there were none of these. So we were quite sure that this is not a malignant lesion. Additionally, on day 1, we did a J needle biopsy, and its result was available on day 5, and which showed that this is a case of a simple bone cyst. So the diagnosis was now, confirmed that this was a pathological fracture through a simple bone cyst in the femur neck. And now we had to go ahead with the definitive surgery. Before the surgery, there were some questions that we needed to, some dilemmas in my mind. Number one, what is the risk of complications in this particular surgery? Because we would have to counsel the parents accordingly. How would I reconstruct this neck, considering that it's a pretty large void extending right from the lateral wall going up to the physis? And number 3, what should be the choice of my implant? Now, considering the complications, if you look at literature, this the pathological fracture through proximal femur benign cyst, the rate of complications is very high. In the union is most often delayed up to about 5 to 6 months. Avascular necrosis rate is about 50%, and the need for revision surgery is as high as 64%. So we counsel the parents accordingly beforehand. And what implant should we use? Okay, so for that, I think the Dorman's classification is a very good classification, which gives us an algorithm on how to fix different types of proximal femur simple bone cyst pathological fractures. And our fracture, it fitted into type 4B, which actually they suggested fixing with the screws. But since our lateral wall was not that large, we decided to use screws with a side plate. So with that, how should we reconstruct the neck? So that was another dilemma. Now, because this was such a large cyst in a weight-bearing area, the usual recommendation for simple bone cyst is packing it with either cancellous bone graft or calcium sulfate granules. But in this case, we decided to use the fibula strut graft, because I thought that this kind of a cyst, this large cyst, unstable cyst, it required stabilization with a strut graft, and that's why this was our surgical plan. So we first started off with curettage. So we approached the cyst through an anterolateral Watson-Jones approach, and we opened up the cyst and we did a thorough curettage of the internal walls. Then we inserted the fibula strut. So we reamed a canal from the lateral cortex into the epiphysis. So this was done with the reamer, and following which we inserted a fibula graft through that tract. And then we fixed this up with a proximal femur locking plate. So these were the intra-op C-arm images. And then around the cyst, whatever void was remaining, we packed it up with ilia crest bone graft. So this was the immediate postoperative X-ray. This is an X-ray at 1 month follow-up. And this is an X-ray at 2 months follow-up. So you can clearly see now that there is some collapse. Though we have put that strut graft, what has happened is that the neck has collapsed, and with that, the PFLCP screw, it has penetrated into the joint, and we knew that we were in trouble at this point of time. So this was at 3 months post-op, and we told the patient that this can't go on. We will need to do a revision surgery. So this is what we did at the revision surgery. We removed the earlier implant, that is the PFLCP, the proximal femur LCP, and we replaced that with a dynamic hip screw. In addition, in order to facilitate healing, we did a subtrochanteric valgus osteotomy, and then the void that was there in the neck, again we did a repeat cancellous bone grafting, and the fixation was done with a DHS, a sliding hip screw. So this was the follow-up. This is a 3 months post revision surgery. This is 1 year post revision surgery, and at this stage we were still worried that maybe we might land up with AVN, and you can still see some void on the superior aspect of the femoral neck. This is 2 years post-surgery. And finally, this is 3 years post-surgery. So the child is doing pretty good. If you classify this healing I would classify this probably as a type 2 healing with a radiolucent area less than 50% of diameter of the bone with enough cortical thickness. And these are the functional results. So overall, the child is doing quite well. So what are the lessons I learned from this particular case? Number one, proximal femur fractures following benign bone lesions, surgery is mandatory. Number two, for large unstable lesions in adolescents, don't rely just on cancellous graft. You will have to probably use a fibula strut graft as well. Choice of fixation depends on age, body weight, location of the lesion, and intactness of the lateral wall. For neck lesions abutting the phoesis and with a compromised lateral wall, rigid screw plus side plate fixation should be preferred. And for large unstable lesions with impending collapse, probably a sliding hip screw should be preferred over fixed length implants like PF-LCP in order to facilitate some collapse at the fracture site. Thank you. So that's all from my end, and I would open up this case for discussion. Look forward to your comments and critique.
Sandeep, a great result in the end for a very difficult problem. And my comment more is on this, in the slide, the paper that you quoted, every single one of them, the screws were stopping short of the physis. So can you kind of explain about, clearly you went into the head and fixed. How would you treat those cases? Because, we have 500 people that are listening to this. We want them to take away with how to manage some of these neck fractures.
Yeah, so, for fixation, I would follow the principles of a standard femur neck fracture, and which is the main principle is stability gets precedence over saving the proximal femur growth plate. And, so if my fixation is going to be compromised, then there is no point in stopping short of the growth plate. That fixation is going to fail. You are going to land up with bigger problems. Proximal femur growth arrest, as we all know, it is not the main growing end of femur. So I don't mind, if it is compromising my fixation, I don't mind crossing the physis. Absolutely, it should be done without hesitance.
Yeah, I think the takeaway for everybody that's listening is that do not ever hesitate to cross the physis. On each and every one of those examples that were shown in that paper, there was very little metaphysis to hold on to. And with some screws, even proximal femoral physeal separation is reported especially if you use a screw, you tighten it, you can separate it. So, and that would be worse than developing any kind of proximal femoral growth disturbance. Sukhdeep, what would you do? Would you do anything different?
First of all, Sandeep, congratulations on getting a good outcome in that case, because that is a really difficult case, and it could go south in many, many ways. And you did a great job salvaging that. I don't know how you argue with success, and you got there. So I'm not sure I would do too much different. The only thing I would say is sometimes I have, it's not very nice in an older kid, but I have said I'm going to throw the kid in a hip spica on top of things just to make sure to supplement, the stability for a short period of time. But other than that, I don't really have too much to add. So nice job.
Some questions and comments from Dr. Antau from the BOS YouTube channel. If you could see them in the chat box.
Yeah, well, we look at that. Courtney, would you do anything different?
I think that I agreed that was a really tough case. I think that, again, like Sukhdeep said, hard to argue with a good outcome. I had a question. When you're using your fibular strut graft, are you using allograft or autograft?
No, our place we are using mostly the autograft. Allograft is not so easily available at our place, and that's the reason we usually end up using autograft most of the cases. And in this case, it was not even the entire thickness of the fibula that we used. It was just the half of because he had a very thick fibula, so I could just leave the anterior half intact. So it was not like completely removing an intervening segment of the fibula. It was like a sagittal cut through the thickness of the fibula. So only the posterior half was taken out and inserted into the neck, and that perfectly fitted into the the diameter of the reamer.
Thank you.
Okay, so
thank you.
I think there's a question in the chat. It's whether do you split the fibula and use it with cancellous graft?
Yeah, I think I just answered that. I split the fibula in this particular case.
Fantastic. Any other questions? We'll post it in the chat, and I think our, we can answer them if we want to keep moving. Sukhdeep, comment?
Sandeep, just one other question, I guess, related to that. There are some newer bone graft substitutes. What do you think the role for those is in these types of cases?
Yeah, I mean, you're talking about the powder in powder form or granule form. So yes,
there are some forms exactly that now you can inject them and then mold them, and so that you can contain them within a certain space, or anyone that you're familiar with using. Do you think there's any role for those in these particular cases?
I mean, in cases where the bone graft, autogenous bone graft is not adequate, we can definitely use the calcium granules. I've used it quite regularly. But the one you are talking about, which are injectable and they will set into the cavity, I have not used them so far, so I can't comment on that. How about you? You have used that?
I've sometimes used it in combination with cancellous autograft, and they seem to do well. But my past experience has been mainly in contained lesions, and I just saw this is what happens when you find out about new products, right? I just saw a new one that sets a bit faster and then is moldable, and they say you can use it in a lesion that's not necessarily contained, and so I was wondering if you had any experience with that.
No idea. Sorry.
All right, folks, let's keep moving ahead. We've got two more interesting cases by the Young Brigade. So, Courtney, over to you.
All right, so this is a case on a missed traumatic hip dislocation. So I'm going to take you back to before I was even done medical school in 2014. There was a 4-year-old female who had presented to the emergency department in a rural Saskatchewan area after a tobogganing accident. She presented with left-sided knee pain. She was unable to weight bear and unable to extend the leg on exam. Imaging was done in the emergency department just of the left knee. There was no fracture, no joint effusion. She was discharged home from the emergency department with no follow-up arranged and was told to be weight-bearing as tolerated. She came back to the emergency department 10 days later with a chief complaint of ongoing left-sided knee pain. Again, still unable to weight bear on the left lower extremity. Imaging was done of bilateral knees this time. This was a supine view. It was reported as normal by the radiologist. Of note, you can see in this x-ray that the knee heights are different. Again, this patient was discharged home from the emergency department, again with no follow-up plan, and was told to weight bear as tolerated. She presented back to the emergency department 6 weeks later. She was unable to weight bear on the left lower extremity. She was seen by a nurse practitioner this time who did a bit of a more thorough exam and found that there was a leg length discrepancy and had described a positive Gautam in her clinical note. She had done an AP pelvis x-ray and there was found to be a left posterior hip dislocation. Peds ortho was immediately consulted and an MRI of the left hip had been arranged. So this was her preoperative MRI, showed a left posterior superior hip dislocation. There was complete disruption of the ligamentum teres. There was no evidence of any associated fracture on the MRI. There was thankfully no evidence of any early AVN, and the sciatic nerve was found to be intact. This was the preoperative examination noted by the orthopedic surgeon on call. So there was a positive Gautam. There was extremely limited abduction of the left hip of about 20 degrees. She did have a normal neurologic exam. So she was taken to the OR a couple of days later. At this point, she's about 2 months post initial injury. She was taken in for a left hip MUA. It was found to be non-reducible under closed reductions. They proceeded to do a left hip open reduction using a posterior Moore approach. The femoral head was found to be buttonholed through the posterior capsule. They explored the sciatic nerve. It was found to be intact. They did find an osteochondral fracture that had a donor site of the posterior aspect of the acetabulum, but this was not amenable to any fixation, so they excised the fragment. They did a labral repair and a capsular repair, an adductor tenotomy to improve range of motion, and they placed the patient in a 1.5 leg spica for a total of 6 weeks. So 6 weeks post-op, the spica was removed. Things were looking good. As early as 6 months post-op, you could start to see a little bit of widening of the medial joint space, a bit of flattening of the femoral head, and starting to see a bit of lateralization, subluxation of the hip. So at the 2-year mark, the plan with the operating surgeon was to return to clinic in 1 year. She was lost to follow up. A new referral was sent to my clinic when I first started practice. At this point, she was about 9.5 years post-op from her initial surgery. So she was 13 at the time that I met her. She was presenting with left-sided hip pain. She had about 3-month history of pain, worse with activity, no feeling of instability, no mechanical symptoms. Her pain was starting to certainly impact her quality of life. When I examined her, she had a very large body habitus. She had significant Trendelenburg gait with abductor weakness. She had some pain over the GT bursa, but she had pretty well-preserved range of motion and just some pain with both flexion and abduction type movements. This was her x-ray when I saw her. So she had an increase in her head shaft angle compared to the contralateral side. She certainly had some lateralization of the femoral head. She had a bit of early sclerotic changes on the acetabulum. My plan at that point, given her significant weakness and the pain over the GT bursa, was to trial some conservative management. So we went and trialed some physiotherapy for abductor and gluteal strengthening, and I plan to see her in 3 months. 3 months later, she presented with similar symptoms and some minor improvement in her abductor strength. So my plan at that point was to take her to the OR and perform a proximal femoral varus osteotomy. I did preoperative imaging. My osteotomy looked like this postoperatively. I gave her about 25 degrees of varus and about 10 degrees of derotation based on my pre-op imaging and physical examination. 6 weeks post-op, I progressed her to partial weight bearing. She was sent to physiotherapy for abductor and glute strengthening. At 3 months post-op, things I thought were looking great. Her pain at that point had fully resolved. She was weight bearing as tolerated. She continued to have some mild abductor weakness. I told her to continue on with her activities and I would see her in 6 months' time. In 6 months, I did a telephone follow-up call because I saw this x-ray. This x-ray was actually reported as normal by the radiologist with no interval change, but you can see an obvious atrophic non-union with hardware failure. A couple of her screws had been broken. I did labs, so CBC and CRP, they were both normal. She was feeling great. She had no signs or symptoms of infection. So my plan for her at that point was to take her back to the OR to do a revision ORIF and bone grafting. So I took her to the OR. When I got in there, multiple screws had been broken. There was a bit of a windshield wiper effect from the blade that I had removed within the neck, which made placement of my new hardware a little bit difficult because there was a big void within the neck. So I had to cheat my locking screws a little bit in the locking plate so that I could get adequate fixation up the neck. Prior to placing my new hardware, I had freshened up the osteotomy. I stuck a curette both up and down the canal to try to get some good local cancellous bone graft. And I also wrapped the osteotomy site in Medtronic Infuse, which is a recombinant BMP product. Intraoperative cultures were also taken, which were negative. I made her non-weight bearing for 6 weeks. She came back in 6 weeks. You could still appreciate the osteotomy site. At 12 weeks, I decided to progress her to weight bearing as tolerated after obtaining a CT scan, which did show a little bit of bone healing and union along that posterior lateral border just under the plate. 16 weeks, which was just on Friday, I got this image. I was a little bit more reassured because radiographically you could start to see the development of some union just beneath the plate. She has been pain-free for the last month or two. She's been weight-bearing as tolerated. Her mother states that her gait has improved significantly. So I guess my questions that kind of arose during this case and after reviewing it was, could there have been a role for earlier intervention when the hip was starting to show those early signs of lateral subluxation? Should I have done anything, given that there were some signs of degeneration on her preoperative imaging when she presented at the age of 13? And after the non-union, should I have changed my fixation strategy in terms of implants to something such as a cephalomedullary nail?
All right, we open it up to the panel. Any comments, Al?
No, not really, because it really was a challenging case. Courtney, thanks for sharing that with us. And I love your resilience, that with failure, you really have to get behind it and sort it out as soon as you can. So really a wonderful case to discuss. And I don't think I would have done anything differently in this case. Sometimes it's just bad luck that, things don't go the way we plan. But I think everything else is great. Thank you.
Sandeep, any comments?
So in the first X-ray, which the previous surgeon had seen, where it was going into a progressive subluxation, the child was around 5 years age?
She was 5 at that point, yeah.
So, I would like to ask you as well as the other panelists, any role for the medial screw epiphysiodesis at that, but I don't think that technique was, known at that point of time, 10 years ago. It's a more recently that, that technique has been popularized.
I
So would
had
you consider that if you see that child now,
Yeah, I had questioned the same thing when I was going through the X-ray. Would have medial guided growth have been effective in this? But then I kind of wondered, was the lateral growth plate too sick to have really created any difference as well? So I had the same thought and I was back and forth. But again, like you said, that technique is quite new. So
Also, I think that it was not the valgus that was a problem. It was the medial joint space which was increased, and it was subluxating laterally, not the valgus per se. I think means whether that screw would have actually helped, doubt.
Carrie.
I'll just, in terms of the guided growth, we have done that a long time in Melbourne, and probably did not really publish it though, which Kishore is aware. But I would just be aware for people about trying to do that in a child that's too small. There's just not enough real estate in the inferomedial femoral epiphysis to really get screw purchase. So just be very careful if you're going to undertake that at that stage.
what is the age at which you would consider that to be an option?
I usually would leave it for like 6 and up. 5 is definitely tricky depending on how much bone you have to work with.
So even when we do it in CP, if you have a very small, thin child who is 6, it's usually a bit of a challenge. So I think she's right.
So that's interesting that you say that, because at the EPOSNA meeting last year, they said the exact opposite. So they said you don't have to have bony purchase with that screw. Cartilaginous fixation is adequate, and that they're actually recommending that you do it in even younger patients. This was particularly in the CP population. So they're saying that the efficacy, the group that they're seeing the most efficacy in is even younger than that, so 2 to 5. And so if you wanted to work, that's what they're doing it at that young. So there's obviously some controversy there, Carrie.
Yeah, my concern is if you end up with a screw that's penetrated the joint, then that will be a problem. So there's the nuance. There's probably somewhere in between. That's the answer.
Yeah,
I think arthrogram would be mandatory if you are doing it in a, in that age group. Yeah.
I think that warrants a whole webinar on its own about, guided growth for.
Yeah, we still have.
Yeah. For what we got one more case to go.
True. Chintan, quickly.
Yeah, can you see the slide? I am just
Yes,
unmuting
yes,
myself.
please start.
Okay. Yeah, so I'll share a case of slip capital femoral epiphysis. What I do differently than, okay, just a minute. Yeah. So a 12-year-old girl with a history of pain in the right hip since 3 months and unable to walk suddenly since 5 days. There was no history of fall or injury as such, but a sudden jerk while getting up from bed was the history what was given. So this was the X-ray that presented to us. Straightforward, that's a severe slip, and by the history, it is acute and chronic. The pain has been persisting for over 3 months, and it's unstable because the child is unable to weight bear since last 5 days. So acute on chronic in a 12-year-old girl. So since we are on a case-based discussion, and I was told that we need to plan, how one would approach. So when this was present in a local meeting, it was more like those who are not trained in surgical hip dislocations. They were like do in situ pinning and treat the cam later. Surgical hip dislocation was for those who are more trained, and those are a handful of surgeons. Modified done osteotomy again through safe surgical dislocation. And what other options can we do for those who are not practicing these cases very regularly? So, as we all know, for slip capital femoral epiphysis, we do safe surgical dislocation, very well described by Gans in his paper, to preserve the vascularity to the head. But what other approach that we all are very familiar with is anterior Smith-Peterson's approach. We use it for so many other cases like DDH, septic hip exposure, or going anteriorly through the capsulotomy. So I thought, how can we approach this, in a simpler way? And I learned this technique from my guru, Dr. Patwardhan. He always says that how we could do it, any technique, any surgery, more simpler, be less morbid for the patient, faster, reproducible by those who are even not trained, and achieve better or at least similar results to the standard technique, and what is best for the patient. So since the last X-ray was more than 5 days old and there was no other X-ray taken pre-operatively, I took a CM check before surgery. I saw that the slip had gone further, more in a severe stage, and it had slipped further. So going by the more known approach for a general orthopod, a Smith-Peterson's anterior approach, going between the sartorius and the tensor fascia lata, and doing an anterior hip capsulotomy, exposing the neck and the femoral epiphysis. Obviously, here the epiphysis is lying posteriorly and more medially. So you won't see the epiphysis, but what you'll see radically when you open the capsule is you'll see the neck there. And as soon as you do the capsulotomy, you get rid of the, the hematoma, which is compressing on the vascularity of the femoral head. So this was what was done. We approached to the anterior approach, did capsulotomy, and then did a subcapital cuneiform osteotomy, preserving the posterior vascular supply. This is going from anterior to posterior. So triangle, the base of the triangle is based anteriorly, and it is better approach rather than going directly posteriorly and affecting the vascular pedicle. So it shortens the neck, preserves the vascularity, and it also creates a space for reduction of the neck, and it shortens the neck so the vascularity is not stretched posteriorly, leading to avascular necrosis. Then by gentle reduction of head, this is a dura retractor. So just by gently maneuvering the head onto the neck and doing a gentle internal rotation of limb, slowly getting the head over the neck and fixing it with a screw. So this is how I approached this case. And this was the intraoperative images. And, I used 2 screws to fix the head to get the hold. And then the vascularity check we did. So we see a good bleeding head. Not that it proves that, it's not going to catch AVN later, but then at least documented evidence that the vascularity was intact even after the fixation. And fixation is good. The rotation with the neck, the head is, moving. So the post-operative X-ray is this. And now we have a 2 years follow-up. There is some shortening of neck. I assume there is some kind of AVN, but then the head is preserved still. The screws are not penetrating. The head is round, circular, and very well in the hip. There's a good Yeah, so there's a range of the walking video, and the child is able to do squatting and cross leg sitting. We'll ask her to do that. And a little lurch, I guess it is because of the neck shortening. There is, on examination, there is about, I would say, 8 millimeters of shortening. I've not done a scanogram yet, but then, yeah, that is what is there, but it is not visible clinically. So cross leg sitting and squatting was possible. And we have similar cases done by our fellow colleagues of Dr. Patwardhan, same technique, again a very severe slip, and treated by anterior subcapital osteotomy and realignment. And again, almost 1.5 years, excellent result there. So rationale of using this approach was doing an anterior approach, which is familiar approach to all the general orthopod. We have around 500 of them attending this webinar here. Not a very steep learning curve like a safe surgical dislocation. Capsulotomy here helps us in decompression of the hematoma. Subcapital cuneiform osteotomy gives us neck shortening. Gentle reduction corrects the proximal femoral anatomy, and then fixation of CC screw stabilizes the slip and achieves earlier closure of the physis, preventing further slip. So it is an efficient method. It's a relatively small learning curve, less surgically morbid, less time consuming, and almost similar results of about 10% from what we have seen over the past 5 years. Thank you. So
Case
I'm ready
open
to
to
take
the
any
rest of the
questions.
panel. Comments from Kish, maybe first.
Yeah, no, very nicely done. I mean, I have to say, as far as slip capital epiphysis is concerned, I call it a pendulum theory in orthopedics. We go one way, we come back another way, we try to figure out another way. So I think we keep going backwards. And I agree with what Sukhdeep says, once you have great results, it's difficult to comment what you could have done and what you would have done. But I'll be Carrie.
You're muted.
Okay, sorry, I'm muted. Yeah, really elegant result. I'm super impressed. Congratulations. I think this is a game changer. I mean, in Melbourne, Royal Children's, we did not do this, and there was definitely some cases where I'm like, that shouldn't have had a surgical hip dislocation, right? So I think this is wonderful. Can you comment to everyone just in terms of your choice of screw? Actually, a couple things in terms of judging the amount that you're going to take, the choice of screw and like fully threaded, partially threaded to get compression, and then like number of screws. Thanks.
Right. So, amount of wedge to be taken about a centimeter or so, and usually it is also decided on how chronic the slip is. So, if it is way chronic, you will get a lot of callus, and that will guide you if you have to take a centimeter or centimeter and a half of the base anteriorly. Make sure we don't go posteriorly, anywhere near the vessel. So keep our, the apex of the triangle very, very minimum. But the anterior wedge, we can take about a centimeter and a half. And the second question about the screw, what we have available here is most commonly 6.5 cc screw. And partially threaded or fully threaded actually doesn't matter. It is, you have to cross 2 to 3 threads into the head so as to get a adequate purchase. If you want to get compression, one of the screw I put it with a partially threaded with a washer, but I don't know whether that actually helps. It is basically, if you stabilize it, it's going to start getting healed.
There's actually a question in the chat from Dr. Abu Saleh. Do you do this only for acute slips, or do you do it for acute on chronic because there may be callus there?
Yeah, so acute and chronic. So this case was acute and chronic, and the whole purpose is we are removing that part of the callus which is forming, and we do it for acute slip as well. That will give you more shortening than what we expect post-operatively at a longer follow-up. But there is already callus forming in acute and chronic or a chronic slip. where the callus is at the extra bone. So probably instead of removing one, you may have to remove 1.5 centimeters of anterior wedge.
And a question or a comment from Alaric?
Yeah, I just quickly just reiterate what Kishore said about the pendulum swinging back and forth. And we must give credit to the fact that this is an old technique described by Fish in 1984. So it's just that with all newer techniques coming in and surgical dislocation becoming so popular, we have tended to forget some of the old techniques. And the approach to this kind of a hip some years ago, before surgical dislocation became popular, which many of us were doing, open the hip up from the front. If it's a truly unstable acute hip, the claws pass technique where you manipulate the epiphysis into place, drain the hematoma, it reduces well to its original position and you pin it. But if it doesn't and there's a chronic element to it as well, then the technique that Fish described, where you remove a small little sliver of bone, a cuneiform osteotomy as he described it, and just enough that you don't cause instability. Remember that when you do this technique, it's a bit blind because you don't know what's happening behind. So the posterior cortex of the neck, you'd be really careful. We used to use osteotomes and a burr, especially as you go more posteriorly. And that's the only problem as compared to the surgical dislocation, where you can actually see the back of the neck. Here you can't. It's a blind procedure, so you have to go really gingerly using osteotomes, remove small pieces at a time, and then use a burr behind to reduce it. So just to give credit to the fact that it's a technique which has been described before, and just like Ponseti became popular all over again for clubfoot, I think we must revisit some of these older techniques because they all are part of our surgical armamentarium. Thank you.
Last question
Important.
from Ortho TV. How do you select patients for cuneiform osteotomy versus the Dunn's osteotomy? Oh, that's opening a whole chapter.
So yeah, for safe surgical dislocation, there's a long learning curve. Like even the papers that I mentioned, a person who's regularly doing it, more than 5 cases of such cases in a year would definitely go the safe surgical way and then do the Dunn's osteotomy and reduction. For us who are starting recently and for general orthopods who are watching this webinar, going anteriorly on a more familiar approach would I think this would be better. So for my next few cases, I'm doing this, but then once I'm more familiar with safe surgical dislocation and I'm more confident in doing that, maybe I'll do Dunn's osteotomy. So both can be done actually.
So I think we are well over time, and there's a question for you, Sandeep, but you please answer that on the YouTube channel live chat now. I think we would definitely like to summarize. So when Kishore and I thought of this webinar, we thought that, DDH is usually what we always keep talking about. But in the pediatric hip, there are lots of other hip pathologies which need careful thinking, planning, and decision making, which is more or less like a tightrope. So we just tried to highlight each of these etiologies, and you learn from masters, you learn from young dynamic surgeons, you can learn from everybody at every stage of their career, because I think learning never stops. So I'm grateful to all the faculty for highlighting different aspects of everything. We'll just take one last closing comment from Kishore, and then Ashish Fadnis, our BOS secretary, can do the vote of thanks.
Okay. Thank you for being here. And I was told there's over 500 people online. This is quite a well-attended rounds. And we've had amazing faculty, and we've seen quite different cases. And Rujuta was intentional about not doing DDH, and that's the most common hip condition. We always go back there. And there's still a lot of work to do in pediatric hip, and that's why we have a network called the Hip Hope Network. We're bringing people together virtually and in person, trying to see if we can advance some understanding of pediatric hip. But I want to thank all the panelists. They put a lot of time, and for you guys in India, it's Saturday night. It's almost 10:45, almost 11 p.m. And for those of us, it is Saturday morning, and all of you have given your evening and weekend time to be here, so we can all learn together, and also we can also probably share our knowledge and our experience with our colleagues around the world. So thank you BOS for partnering with us. It's it's been a pleasure working with you all, and we have a long connection with Bombay and Mumbai with Al and Rujuta and Dr. Johari, and we'll continue to collaborate with you and expand those collaborations. Thank you.
Thank you very much, ma'am. And thank you very much, Kishore. I would like to thank all the panelists as well. And thank you to our president for being throughout this session. It was a wonderful session, and we learned a lot as being general orthopedic surgeons. And that is the enthusiasm is seen from the fact that there are still questions coming into the chat. This videos will be live, will be sort of, played on the YouTube channel, on our website, as well as on Ortho TV. And I would like to thank Rishi and Dr. Neeraj Vijlani and Ashok Sham from Ortho TV for hosting us and doing all the technicalities and logistics for this webinar. And our webmasters, Dr. Gaurav and Agnivesh Tikku, thank you very much for being there and firefighting and channeling all the questions. And lastly, this would not have been possible without the participation of all the faculty who is with us. And thank you very much once again. We'll see you all again next month. Thank you very much.
Ashish, we should take this opportunity to invite the Canadian Pediatric Orthopedic Group for YROC 2025, Carrie, Courtney, Kishore, Sukhdeep. I know it's Christmas time at that time, but December 26 to 28 is YROC, and we are looking forward to a grand pediatric orthopedic session over there. There'll be at least 2, if not 3 sessions. And we would really, really appreciate if one or more of you would come. We would be glad to host you in Bombay. And Rujuta will reach out to you on our behalf. And if you can make it, we will be most delighted. Thank you and good night.
Thank you
very much.
Thank you, sir, for the great
Bye-bye.
session.
Bye.
Marish, you can stop recording.